Order, order. Welcome to today's extraordinary session of the Health and Social Care Select Committee, which has arisen after the recent announcements of the reorganisation between NHS England and the department. So I thank, first of all, the Secretary of State for making the time to come and see us before Easter, as he promised at the dispatch box. I'm extremely grateful to him. With him, we also have Sir Chris Whitty, who is, of course, the Chief Medical Officer and Interim Permanent Secretary. Welcome, Sir Chris. Thank you for being here. And especially warm welcome to Sir Jim Mackey, the first time in front of this committee, having been enrolled for just a week now. So thank you so much for appearing in front of us, all three of you, on this beautiful day. Thank you. So, Secretary of State, if it's all right, because you've been very busy and have made some announcements recently on mental health. So if we could start on mental health, and then we will move to the substantive questions on the reorganisation. Now, there was a dear colleague that showed that mental health spending this year, as an overall spend, will be going down. My understanding is, and correct me if I'm wrong, but that is a reversal of a trend that we've seen since 2018, where it's gone up incrementally year on year since that point. Now, it's the first time. What does this say about the government's commitment to parity of esteem?
Well, actually, I mean, mental health spending is increasing in real terms for the coming year.
Proportions decreased,
But
right?
the proportion has decreased by 0.07%.
But what is that worth in monetary terms?
It's worth probably 100, 200 million pounds.
And that's not small change.
In that order, but it's got to be seen in the context of the 26 billion pounds the Chancellor allocated to health and social care, which kicks in this week, much of which is directed towards many things that we committed at the last election, including the serious amount of investment going into our elective reform plan and the wider investment in the health service to help recover services. The mental health part of our plan involves real terms increases in spending, delivering on the manifesto commitments we made. And, you know, if you look at where we are in relation to recent years, as you mentioned, it's 8.71% of spending in 25-26 of NHS spend. It actually decreased last year under our predecessors. We're not in a bad position. And as I say, for people who are watching this closely and care about mental health investment, a real terms increase in spending will mean real improvements for people in terms of accessing mental health services. So I don't want people to draw from my answer any hint of complacency. We are delivering the mental health investment standard through ICBs. So in terms of the investment in services, people should start to feel improvement in mental health services as well as improvement across the rest of the NHS.
You mentioned a previous figure, but say that that's a decrease from the year before. Would you be willing to publish the numbers from all the years? I mean, are they?
Yeah, they're certainly available, and the library would have those figures. But I'm happy to share those with the committee as well.
Because my understanding was that this was the first year that there was a drop, not the second year. Because what I'm seeking here, Secretary of State, I mean, you'll know the Darzi report itself points out that 20% of the spend in burden on the NHS is in mental health, and yet we're spending less than 10%. And that was, in the context of that report, very strongly made as something that was unacceptable. And yet what we're seeing here is an overall decrease in spend. And I see what you're saying, that yes, the real terms is increasing, and that is, it continues to be welcome. But we got to this position because as the overall spend in the NHS increased, mental health kept lagging behind. That was reversed in previous attempts by the last government, and this is the first time that trend in proportion has decreased. Is this an anomaly? Can we be assured at least that this is an anomaly and not a trend? Is the proportion going to further decrease next year?
Well, we're committed to the mental health investment standard. That's been consistent and will be delivered for the coming year. In terms of overall proportion of spend in mental health as part of the overall NHS baseline, I would hope to see it rise over the course of the Parliament.
What's the hope about that?
That's all subject to spending review.
Right.
And I think the other caveat I would add, like if you think about the investment we've just put into general practice and the £889 million that's going into general practice, that will, although it wouldn't be classified in terms of these numbers as mental health spend, it is an important part of the mental health pathway for lots of patients, and lots of people who require access to mental health services will benefit as a result of being able to see their GP, or as a result of being able to have follow-up appointments with their GPs for ongoing mental health conditions that are being managed in the community.
Yeah, which of course brings me on to the waiting lists. I mean, the waiting lists for mental health continue to be very concerning. The longest one is nearly 2 years, but that's more than twice the elective. So I understand what you're saying in terms of access to GPs, but are you concerned that this reversal of what was a positive trend in trying to tackle that, plus the changes in the planning guidance, means that you are deprioritising mental health in reality?
No, I really don't accept that at all, because I think in reality, mental health spending is going up in real terms. I think if it wasn't going up in real terms, if the actual spend in mental health was falling backwards, I think that would be a fair charge. But that's not the case. So for 25-26, we'll be spending just shy of 179 million pounds on mental health services. I mean, that's up considerably from 2018-2019. So you can see the trajectory in terms of actual spend on mental health services, a real terms increase for the year ahead. I think that does put us in a good position, not just to deliver on our manifesto commitments, but to deliver improvements in people's experience of and access to and impact of mental health services. Ultimately, that's the thing that matters most. But look, I accept the challenge you're putting to me about mental health as a share of the NHS baseline. That's a fair challenge. As I said in my written statement to Parliament, we were upfront about the where that put us in terms of overall proportion, but I think it is a 0.07% decrease.
Yeah, you're minimising the percentages, but you said yourself, we're talking about millions, hundreds of millions of pounds here. This is not small amounts of money, and as you know, we're running an inquiry on severe mental ill health and community services. What we're seeing in the evidence we've taken so far is this is not a productivity issue here. This is just simply there is not enough out there to meet demand. Let's split the difference. 150 million odd would make an enormous difference out in the community for mental health teams. Do you not accept that would help the rest of the economy, their physical health? We know that there's comorbidities there. There's also a virtuous cycle that way too, is there not?
Of course, whether it's mental health, general practice, dentistry, schools, prisons, across the board, of course it's the case if we had more money available, that would be quite useful, but we're making decisions against a very challenging fiscal backdrop. Nonetheless, we're committing to our manifesto. And it means, and I think I misspoke earlier, so I should just make sure I correct the record, for 25-26 we're spending £15.6 billion on mental health. That is a real terms increase from the previous year. I'm not pretending that there won't still be challenges, but a real terms increase in funding does mean a real improvement in services, and that's what we want to see.
So you did that, but you also removed the targets. Why did you do both? So you could have increased the spending and removed the targets, or you could have you kept the targets, knowing that the spending would, well, not decrease the spending, but decrease the proportion of spending. Why did you decrease the targets at the same time?
Well, in terms of planning guidance, we felt it was important to subject the system to fewer centralised targets. And I think that is going to be a key part of how we govern and how we lead the NHS over the course of this Parliament. The NHS has been overloaded with targets, the planning guidance, and the competing. Let's come on to the change we're making to NHS England. The number of targets being driven from the centre, from not one but two head offices, leads to duplication, waste, inefficiency, contradiction, and the system being pulled in different directions. We're asking the system to embark on big reforms over the coming years, and it's important we give leaders that freedom and flexibility.
Yet the elective targets, as we know, are part of the missions, are very important at a high level. Our concern is, there will be some conditions that you are prioritising over, say, bipolar. Is it right that someone who's got, albeit a severe bunion, will get seen by a specialist first over someone who's got a severe mental illness. Is that right, morally?
Well, we want to see access and waiting times improve across the board, whether we're talking about physical health conditions or mental health conditions. And that's why in mental health we see real terms increases, and the same applies to physical health services as well. And let's not underestimate the link between the two. There are many people on waiting lists at the moment, which despite the progress this government's made of reducing waiting lists 5 months on the trot, including over peak winter pressures, many of those people who are waiting in pain and agony will also be waiting with anxiety and depression because of the debilitating impact of being on physical health waiting lists.
And vice versa. You said in the context of the welfare reforms, because obviously the elective plan has been spoken about a lot in the context of the welfare reforms, but the mental health aspect, can I just ask you about a comment you made about overdiagnosis? What's the evidence for that?
Well, we've certainly seen a debate since I was asked a question on Laura Kuenssberg about this issue, and I think it is a welcome one. I think
what specifically has been diagnosed, and what evidence do you have
let's just look at some of the things that have been said and written since my comments. The total number of antidepressants prescribed in England increased by 36% between 2016 and 2023, with a concomitant 23% increase in the number of patients receiving antidepressants over that period. We've got the BBC Panorama investigation found that patients are being offered powerful drugs and told they have ADHD after unreliable online assessments. And indeed, Professor Sir Sam Everington and Professor Anise Ismail, both distinguished GPs, wrote in the BMJ recently, too many GPs are under pressure to issue fit notes rather than support and properly evaluate the request. There needs to be a cultural shift about mental health so that return to work is recognised as part of treatment, except for severe mental health problems. So I think there are a number of things that are going on simultaneously here, and I think it's so important to kind of distinguish between a whole range of factors and pressures. The first is there is anxiety within the medical profession about overdiagnosis and overpathologising of anxiety, day-to-day stresses and pressures and well-being issues, which, by the way, do require support, but where there are concerns there. At the same time, and I certainly felt this in the wake of my comments to the BBC, at the same time, there are lots of people who are saying, overdiagnosis, I can't get access to a clinician who can give me a diagnosis, let alone access treatment. Both of those things, I think, are true and are also related. And I think we've got to distinguish between people who should be on a mental health treatment pathway and those people where earlier intervention with challenges in their lives early on would stop well-being issues becoming mental illness or, worse still, mental health crisis. And I think that's what we're seeing, and that's why we want to make sure we're intervening far earlier.
I was really struck by, in your answer, you said since you were asked the question. So when you made the comment that there's overdiagnosis, had you not looked into that before? Was this not? Was
no,
this
that's
a
why.
comment
I mean, look, that's why.
Based on evidence that you'd seen before? Because I'm sorry, evidence from a BBC Panorama programme and a couple of articles in the BMJ is canaries potentially in a coal mine. But I don't understand this to be a well-evidenced.
Well, I think those numbers on prescriptions of antidepressants, I think, should be cause for concern.
That could as well be explained by the fact that there is unmet need out in the community, which we're investigating as part of our inquiry, is it not? Yeah,
well, I welcome further debate on this, but I absolutely stand by what I said on the BBC to Laura Kuenssberg, and I appreciate. Sometimes suffer with this affliction of answering direct questions honestly, and that's what I did on Laura Kuenssberg, based on the concerns that clinicians have put to me and lots of families have put to me about anxieties of over-pathologising of well-being issues, and particularly in the CAMS space, young people ending up on CAMS waiting lists with well-being issues which should be dealt with far earlier and more quickly, which is why we've committed to the rollout of IAPS in every primary and secondary school in the country, so that those well-being issues that young people experience do not become mental health illness, or worse still, mental health crisis. We've got to tread carefully in this debate, because what I wouldn't want, and what I certainly think lots of people heard when they heard that interview was the sort of Secretary of State for Health and Social Care saying there's an overdiagnosis. At the same time, they were feeling they were unable to access a diagnosis. And I just say, I think both of those things are true simultaneously, as is often the case in terms of the pressures we're seeing in our health services at the moment. And I think we certainly do, I actually welcome the clinical debate on this, and there are lots of clinicians who are seeing this, supporting what I've said, feeling the pressure, at the same time as people who are cautioning, again, quite rightly and understandably, not to underestimate the level of mental health pressures that exist, particularly for children and young people, but more generally in our society at the moment. I think both of those things can be true.
Okay, let's move on to the reorganisation. So what is the government seeking to deliver through these reforms?
A number of things. First and foremost, we want to make sure that the NHS is well led, and that in terms of the various layers of bureaucracy that exist in the NHS, we're reducing waste, inefficiency and duplication. Where we currently have effectively two head offices for the NHS, we will have one. Where we have duplication of functions across the Department of Health and Social Care and NHS England, we will eliminate that duplication, and that also applies down at ICB levels. We've got too many checkers in the system. We could do with some more doers. We will free up hundreds of millions of pounds in the process that can be redeployed to frontline services. I think that is welcomed by patients. I think it's welcomed by lots of frontline staff who agree with that diagnosis of too many layers. And I just want to sort of say up front, I am mindful that with the scale of the change that we are doing and the level of headcount reduction, there are lots of people whose jobs are at risk. We don't take these decisions lightly, and I don't for a moment suggest that because there is waste, inefficiency and duplication, or that there are too many layers of bureaucracy, that this is somehow a kind of failure on the part of the people who are turning up for work every day, working extremely hard as dedicated public servants. This isn't their failure, but it is a failure of the system they work in. And I wouldn't pretend for a moment that people whose jobs are affected are happy about this change. They will be experiencing the same sorts of fears and anxiety of anyone whose jobs are at risk, and I don't take that lightly. But I think many people working in the department, NHS England, and working in the system would recognise what we describe as that duplication, waste and inefficiency. I think that's the first part. I think the second part of what we were driving at is the biggest devolution of power in the history of the NHS. I think we need to do away from this absurd notion that a system this large, this diverse, this complex can be micromanaged or commanded and controlled by the Secretary of State or the Chief Executive of NHS England, for that matter, pulling a set of national levers. It's our job to make sure that the system has the tools to do the job, to make sure we've got the right people, the right resources in the right place, that we've got the right regulatory environment, and that we are unlocking the as yet unrealised potential of the NHS as a single payer organisation on things like procurement, on things like life sciences and data, and the revolution we're going through in terms of life sciences and medical technology. We've got to make sure that we've got all of those national system enablers. But where is the best innovation coming from? The front line. Where is the real change being delivered? The front line. Where are patients going to benefit most from Labour's reform agenda? The front line, and that's what we're driving at with these changes.
So what do you hope that you'll be able to do as a result of this organisation, as the Secretary of State, as the politician pulling the levers, that you couldn't do currently?
Put even more money into the front line than the Chancellor already is, and it's really important to remember we were elected on a mandate of investment and reform, and even with the £26 billion the Chancellor has allocated, as you alluded to with your opening set of questions on mental health, we could always do with more money for frontline services, so we've got to go hard after any waste, any inefficiency, any duplication. But as the Secretary of State, I think what I'm trying to do is the most radical thing I think you can do in national government, which is win power and then give it away, and make sure that people who are leading provider organisations, that people who are leading the health and care systems have the tools, the freedoms, the flexibilities to do the job, to drive innovation, and to be held to account for the outcomes they achieve rather than being centrally dictated to about the means.
And what will success look like, Secretary of State? So you started, when we asked you this in the context of the 10-year plan, and maybe I should ask that question first. I mean, the timing of this is kind of curious, because you'd think with the 10-year plan coming, form should follow function. And yet we're changing the form without knowing yet what the function's going to look like. We've got ICBs telling me that they need to start redundancy packages by the end of April, when we know very well that the 10-year plan won't be fully finalised and published until at least after local elections. So why have we done it in this order? Why now?
Well, because we know where we're headed in terms of the 10-year plan, which will be published in June around the spending review. I've been clear for some time now that I wanted more devolution of power in the NHS, more power, freedom, flexibility, responsibility closer to the front line, indeed at the front line. And in my NHS providers speech at the tail end of last year, I made it clear that in that context, that the roles of ICBs would be changing and would be becoming more focused on strategic commissioning. I made it clear that senior leaders would be given more freedoms and flexibilities, but would also be better held to account in terms of performance management and of proper failure regime.
It's very top level. Forgive me, Secretary of State, because we're trying to stick very closely to time, but it's very top level. And you've got ICBs trying to make these changes now. You've got trusts looking at, and Sir Jim wrote a day one letter, which we've seen and is published on the website if people want to look at it, where, again, it was very top level. But the detail of this is going to be predicated on the 10-year plan, surely. So when are all the parts of the system going to get the detail they need to make the right redundancy, so we don't end up losing the good people and then not having the right form to follow the function that you want? Well,
as with the planning round that's underway, and with the plans that we're now going to require from ICBs, they will be sending their plans and their proposals for reducing cost and headcount as they're being directed to by Jim as the new chief executive. They will be sending their plans into Jim and his team, who will be checking and evaluating those plans against our priorities to deliver better services for patients. And that's, look, ultimately, that is where and the focus of this government is, and where and how we will be judged. You know, our waiting lists lower, our waiting time shorter, our ambulances arriving faster. It's easier to see a GP and a dentist than when we came to power. That's the yardstick the public will judge us by.
This is my last question before I'll move on, but just so the system is clear, and just so perhaps Sir Jim will chime in very quickly. If they are planning to make redundancies from essentially roles that will affect the front line, that will not be allowed, versus if they're combining comms teams and safeguarding and those sort of backroom, more officey style, those would be fine. I think what we want, bluntly, is reassurance that the teams that are delivering for the front lines, and you'll know I've got a particular interest in place-based teams, which are going to be critical to delivering the neighbourhood NHS that you and I both want. How are we going to make sure that ICBs are not doing that in order to meet these numbers?
Yeah, so as Secretary of State's already said, we've set out a direction. We know where the 10-year plan's going. We've been clear in the letter, but followed that up with other verbal briefings. We've got some ICB colleagues working with us on the future of ICBs and the shape and what sort of functions they will have. By the end of May, it's our expectation that they will have agreed with regional teams what that looks like, how they'll move resource from certain functions into other functions, the functions they'll not need in the future, agree a plan that will then be implemented later on in the year. So there are some checks and balances in it, but the key is, as you've already identified, colleagues have heard the message. We need to pick up pace of change, so this isn't something we could have just waited for because of the financial position and other pressures that we've got, but we are keeping an eye on and working with colleagues to make sure that we don't lose capacity, lose critical staff, lose staff who are actually directly impacting patient care in this process.
Thank you. Ben Coleman.
Thank you very much, and thank you very much all for coming in. Before we talk about a little bit more about what we've just been talking about, can I just throw one thing which is much on my mind, which is about palliative care. Are we looking forward to seeing something in the 10-year plan about improving palliative care?
Yeah, we are looking at palliative and end-of-life care in the context of the 10-year plan.
Is that going to, do you think, produce anything that is radically different from what we see now? Because although we are better than many other countries, our palliative care is awful. It's just worse everywhere else.
You're tempting me to pre-announce the 10-year plan. I mean, we do want to see improvements in the quality of palliative care, and regardless of the different positions we might have as parliamentarians around this committee about the merits of assisted dying, it has certainly generated a broader national conversation about palliative and end-of-life care, which I think is a really good and important debate to have, because ultimately what we should be driving towards is for everyone to be able to have the best possible death. And to break some of the taboos and the conversations around what a good death looks like. So I hope that, regardless of the views people might have on a piece of legislation going through Parliament, that we can create together the kind of end-of-life care and palliative care that I think everyone in our country deserves.
It is good in a few places, but it's just not spread across the country the way it needs to be. And so you're optimistic that the 10-year plan will address that problem?
Yeah, I mean, this is one of many areas where we need to take the best of the NHS, the rest of the NHS.
Thank you. Just coming back to the reform then that we're talking about today, and thank you, that's very helpful on palliative care. We touched on quite a lot of detail about the fact that you were pretty much opposed to doing this reform initially. 30th of January, you told the Health Service Journal that you could spend a hell of a lot of time in Parliament and a hell of a lot of taxpayers' money changing some job titles without making any difference to the patient interest. 6 weeks later, you announced the move, shall we say, of NHS England into the HSE and getting rid of a lot of jobs. What happened in the 6 months? Was there some particular changes that you tried to introduce and you just thought this ain't going to work? And the shock was too great to trying to deal with the current system.
Yes.
So particular things that changed your mind?
Experience in office, bluntly.
Any particular experiences?
I was.
What was the straw?
Even as someone who has paid close attention to how this situation, how this system is run and led as Shadow Health and Social Care Secretary, I was quite surprised at the extent of the duplication that exists between the department and NHS England. I was taken aback by the extent to which policy and strategy, which I think should always have sat with the department and assume had always sat with the department, had become part and parcel of life over at NHS England. I think that blurred form and function. I think NHS England was set up to be the delivery arm, with policy and strategy still supposed to sit with the Department for Health and Social Care. I don't think that's always been the case, and I think that has led to litigation and relitigation of decisions that democratically elected governments, and I include our predecessors in this, have wanted to take. And so there's that kind of part of it. There's secondly the waste, the inefficiency and the duplication I've seen. And look, it goes back to the chair's question in a way of why now and why have we announced this decision ahead of the 10-year plan? Well, it's because it does take time to do what we're embarking on in terms of reducing headcount on this scale and abolishing an arm's length body of this size and complexity. It does take time. Yep. And we don't have time to waste. If we can achieve hundreds of millions of pounds worth of savings every year, foot down on the accelerator.
There was no particular straw that broke the camel's back, though, for you?
No, not particularly. And, I had been talking with Amanda Pritchard as Chief Executive of NHS England about the changes that we needed in the relationship between the department and NHS England, which is why from day one Amanda and I sought to build a new culture, a one-team culture, which I think actually, to the credit of people working in both organisations, had already begun to bear some fruit. And I think about some of the teams that sit around my table in the department. The best meetings are where you can't distinguish who's in the department, who's in NHS England. Some of the worst meetings are when it's blindingly obvious who sat on which side, and it kind of sometimes resembles West Side Story, albeit a very polite version and less musical. But you can't really. I think that's a really good way of working for anyone. And regardless, I think when you
Which side is on Wes's side?
Well, it depends on the issue, and it's really important. I'm glad you asked that question, because it's important for me just to kind of underscore this as the person who's been in this chair for the last 9 months. When I think about my team or the team I'm responsible for, I don't just think about the Department for Health and Social Care. I do think about the people who work at NHS England. That's the culture that Amanda and I were building from day one of me coming into office. And there are brilliant people who work at every level of NHS England. And I'm determined, as we bring these two organisations together, that we are building what is effectively a new organisation with a new culture, new ways of working. And one of my metrics for success will be, a few years down the line, do you still have, as is sometimes the case in the department and NHS England, people still referring to themselves and their job functions based on where they used to work. So it is not unusual to find people who say, oh yes, I was with HEE, even though that's been abolished, or to say I was at OHID, even though that's been abolished. And that, I think those are signs that the culture of team working on one organisation hasn't always been achieved in previous mergers, and that's something I'm mindful of as we embark on this process. But I certainly don't want people to think that because we are abolishing NHS England that we think it's a terrible organisation filled with bad people doing a bad job. Quite the opposite. Some of the most brilliant public servants I've ever encountered work at NHS England, and I hope will continue to work in the new merged.
You're not intending to throw the baby out with the bathwater?
No, certainly not.
Oh, good. So Chris, can I just ask you, who is leading this? Obviously, it's a big change programme. Who's leading it in the DHSC? Is that you?
Well, obviously the political leadership entirely comes from the Secretary of State and
on an
ministers,
operational basis.
But operationally, yes. Whilst I'm on the interim role, I'm leading this. But there is a transformation board which is across both organisations. So Jim and I both sit on that, co-chaired by the chair of the board in NHSE and the board in DHSC. So there's a level of coordination between the two organisations, and then when it comes down to things that are specifically the role of the department, then I will be the person who's dealing with the operational side.
Thank you. Good. And so do we have a target date then for the actual date by which NHS England is to be formally abolished?
Well, we're looking at this as a process up to 2 years, and that doesn't mean that that's when everything is done. There is a process of bringing teams and bringing the organisation together and reducing headcount, which will be taking place starting over the coming months. But although there is much we can do without changes to primary legislation, ultimately the process of abolishing NHS England will require primary legislation, and as we know, that takes time and isn't just down to me, it's down to business managers and all of you as parliamentarians, depending on how cooperative or otherwise you want to be.
That will set out a date for the actual abolition, and so is there some thinking about what that date would be? Not
a specific date, but as I say, up to 2 years. Yes. And in the meantime, and I'm mindful that when you're doing something of this nature, how information and when information is conveyed is a challenge, because in any organisation I've ever worked in where I've either been part of a restructure or led a restructure, you would never have handled the process in a way that in government you inevitably have to. So in an ideal world, we would have embarked on this process with a change management plan already in place, with an organisational structure in place and new job descriptions and organograms ready to go when you start briefing staff about changes. But of course, the moment we started to do that work, which is now well underway, we would have been reading about it in the HSJ long before the Prime Minister announced it or Parliament was informed. So I appreciate that for people who are on the receiving end of some of these changes, this has been a really difficult and challenging time. But the Prime Minister and I have sought to make sure we've handled announcements in the right way. And now that we're clear about the direction of travel, we will be keeping regular internal communication up with staff whose jobs are affected.
That's very good to hear. Well, I just want to ask one more thing, which is about the move to community and the funding. of that, because it's partly to do with accountability. But we have, are we going to have in the move to community a sort of NHS typical top-down single model, or is it going to be different models? Sometimes the move to community will be led by GPs, sometimes led by ICBs where they survive, sometimes led by hospitals. But it'll be a different models permitted. And while that happens, is there going to be double running, funding both secondary and primary care, or is secondary care expected to going to lose money for this?
I'll say a few things, and I'll bring in Jim as well. Firstly, ICBs are here to stay, so there is not going to be a kind of an NHS reform bill that abolishes ICBs. As Jim alluded to in the HSJ, what we have encountered is a demand against the reductions we've asked ICBs to make, and the attempt to go after duplication and the challenge we've laid down for them. We've had a demand from some ICBs for permission effectively to look at whether some ICBs should merge and be consolidated. And we are very receptive to and responsive to that kind of demand from below. And I hope actually we see more of this kind of two-way interaction and leadership within the system. It can't, if it's always top-down command and control, we will fail. And the more we get that pressure from below and that hunger to change, I think the more we will be succeeding, whether that is system leaders in ICBs or frontline clinical teams who are changing the way they do their elective surgery, for example, and having the support of executive leaders to do that. So that's the first thing to say. The second thing to say is absolutely, and in that spirit of devolution, I think one of the reasons why the NHS isn't performing as effectively as it could, and why we see such variation in performance across the country, is because there has been too much top-down diktat about how services are configured. And clearly, how we design and deliver community and neighbourhood services in my part of North East London, sort of West Essex, will look very different to Cumbria and Cornwall. And it's important we give communities and system leaders that freedom and flexibility to do the kind of place-based planning and delivery of services that the chair was referring to earlier. So we're going to take a test and learn approach, give more freedom, more flexibility, more powers to the front line. What we'll be judging them from is outcomes. Is access improving? Is quality improving? Are outcomes improving? And are we reducing health inequalities in our country at the same time? Those are the key tests. Jim, I don't know if there's anything you wanted to say.
On the double running point, just to clear, are we going to take from Peter to pay Paul? Is secondary care going to pay for primary care while this happens, or are you going to continue to fund both while the new community approach is developed?
I think it's a bit of both. I mean, we can't afford, against the backdrop of the challenges that we have, the luxury of kind of double running things all over the shop. It's one of the reasons why we're going after unnecessary duplication. But I think what we are beginning to see in different parts of the country, and you've obviously seen on the front pages in recent days some of the reports of some of the neighbourhood-based teams, I think, and the pilots that are running, I think there's a combination of approaches. In some cases, we will actively fund pilots and take the sort of test and learn approach to trialling new things. In other cases, system leaders and provider leaders are looking carefully at how they are spending public money and how they are configuring services, and are concluding that actually, rather than pouring more money into another set of secondary care services, it would be better for the secondary care provider and their patient outcomes for some of that money to go into primary care or community services or social care. And I want to see more of that system leadership and system thinking.
I'm going to come to that. I'm sorry, we need to move on, but we're coming back to ICBs and community. Jen Croft.
Thank you, and thank you, Secretary of State. Before I get on to the questions that I've got written down, I'd just like to circle back to some of the discussions you've had around welfare reform, as it strikes me that your department has a particularly strong role to play in making sure that this is a success and that it delivers what it says on the tin. I'm particularly interested that there seems to be a move towards PIP supporting those with higher needs and not those with lower health needs. And I note that the Green Paper states when it's looking at that there will be some people who are no longer eligible for PIP but yet they have health and care needs, that everyone should have their health care needs met by the NHS, and that DWP will be working with DHSC to make sure that this happens. So I'm just interested as to what kind of assessment your department has done to identify people who might not be able to access PIP in the future, but yet still have those health and social care needs, and how will DHSC pick up that need and make sure that these people don't miss out?
So I'll say a couple of things. Firstly, my department and the Department for Work and Pensions has a really good working relationship, including a joint health and work team who are doing some really innovative things through the Work Well initiative and through some of the work we're developing together in the context of the forthcoming spending review to better integrate health and work pathways, because we recognise, and I certainly recognise as a constituency MP, that a brown letter coming through the letterbox from DWP can often be a source of anxiety rather than a welcome approach. And often when people hear terms like welfare reform or getting people off welfare back to work, what people fear is that means a stick approach and being penalised into finding work. And as we've seen in some places like the Maudsley, in South London, some of the encouraging initiatives we're seeing come through Work Well, integrating health and work pathways means that people who do have ill health, which is whether mental or physical ill health, which is at risk of preventing them from being able to find work or stay at work, joining up the employment support and the health support is a more supportive way of working. It delivers better outcomes and it makes people feel genuinely supported back to work rather than penalised back to work. And Liz Kendall and I have heard that firsthand from people who've benefited from that approach, or the pride of people who are involved in delivering those initiatives. In terms of the impact of the Green Paper and the welfare reforms being brought forward by DWP, the DWP are obviously doing their impact assessment and reporting, and it's up to us, regardless of the welfare changes, to make sure people's health needs are met.
And I know you said it's up to you, but has there been a discussion about where budgetarily this lies? I'm very aware that Westminster suffers probably from silo working as much as anything else. And it feels, if you were to read the Green Paper in a certain light, it does feel very much like a pushback from DWP saying we shouldn't necessarily be paying for this. I think the phrase people's health and care needs should be met by the National Health Service seems to be speaking about potentially DWP having paid for things in the past that they feel that they shouldn't have paid for. Is this the kind of discussions that you're having about who should pay for it?
Well, firstly, I should say there's not a day goes by where a colleague in government doesn't come and knock at my door and suggest there's something the Department for Health and Social Care shouldn't be paying for to help them with their goals and their priorities, and vice versa. I think that's partly the nature of government. I think it is also true to say that there are areas of health activity provided by DWP where I think we need to take a more team-based approach to making sure those services are properly designed, delivered and funded, and the Work and Pensions Secretary and I work really closely together, our departments do as well, but we've got to make sure fundamentally that people's health needs are met. It's one of the reasons why, take electives for example, one of the reasons why we launched the Further Faster 20 initiative was to target those areas with high numbers of people who are off work, off sick and on an NHS waiting list. So you've got high waiting lists, high levels of economic inactivity, because I'm mindful of the fact that it's our responsibility to get people back to health, and in many cases that won't just mean back to health, that will also mean back to work as well, which is good for everyone.
And I do note that it is a cross-government initiative. I think probably speaks to mission-led government, but it usually comes down to the money. Just to touch on the impact, I would say, in this, of perhaps some of the narrative around welfare reform, have you had any idea of whether that has had a negative impact perhaps on people's mental health, and whether you will see an increase in some of those waiting lists as a result?
No, not at this stage. And I think it's partly on us as government and as parliamentarians to make sure the detail of welfare reform is properly understood. I met a constituent at the weekend, for example, who was very concerned about what the welfare reforms would mean for her, and she's on universal credit, not PIP. And so I totally understand, against the sort of political backdrop we've had over the years, that there are lots of people for whom the welfare system is a safety net or a lifeline, who when they hear welfare reform kind of worry, and I think that's almost kind of inevitable given where we've been as a country, but it's really important that we also get across the kind of the facts, the detail, and then as members of parliament start to make judgments about cases where people are impacted, and being, you will understandably challenge us if you think we're getting this wrong, or if we're drawing the eligibility lines in the wrong way, or if there are people or edge cases that we've not considered or overlooked. That's part of the process of parliamentary scrutiny and accountability. But overall, what is the government trying to do on welfare reform? And we're trying to make sure the system is sustainable, to make sure it's there for people when they need it, to make sure it's not just a safety net when people fall on hard times, but it's also a springboard back to work, that we're not writing off people who are ill or disabled where they want to work and are able to work, and most importantly of all, perhaps, making sure that where people are so ill or severely disabled that they literally cannot work, that they are provided with the level of support they need to live a happy, dignified and independent life as possible with their conditions. And that's what's driving behind the welfare reform agenda.
Thank you. And I think just one final question on this before we move on. Just wanted to come back to the overdiagnosis of mental health comments. I wonder if there is some pressure and a view that there are people who potentially have been overdiagnosed with a mental health condition who are off work, who could be in work, and if there is any leniency in the system. So I know, again, the Green Paper points to people having to engage and having an expectation of engagement with employment advice, and that includes signposting to mental health and physical health services. However, you will know that in quite a lot of areas these services just simply do not exist. Has there been thought given around potentially, if you were just to have a hypothetical example, someone who's experiencing a mental health condition, their mental health has become worse, they may have, if you want to argue overdiagnosis, we can, but their doctor may have signed them off work, prescribed antidepressants. However, there's a 9-month, 1-year, 2-year waiting list for talking therapies. In the meantime, they can't go back to work because this is not available for them. Is there a leniency, or is it just because they've been signposted, they're expected to get on and find that support?
I think in cases like that, it's why actually integrating mental health and employment support pathways is actually a really good thing to do, because it makes sure that people are receiving the holistic support that they need. And just because someone is suffering from mental ill health, it doesn't mean that they should be written off, and it doesn't mean that we should make an assumption that they are unable to work, or that as employers we shouldn't try and show a degree of flexibility, and that with the right support people couldn't be supported to stay in work or to find work. And I think there's you kind of have to handle these conversations sensitively, but there is lots of people who would say, either through their own experience of their mental health or their experience of providing mental health and support to people, that if you can get someone back to work, that is also good for their mental health, because it gets them out of the house, socialising with colleagues, feeling like you're sort of getting back on your feet. And in some ways, the people I worry about most in this sort of context are the people who, whether initially through a mental health challenge or a physical health challenge, finds themselves off work, stuck at home, and feeling increasingly despairing about their position, either because of their physical health situation, which then is added to because of mental health anxiety, or because their mental health conditions saw them come off work for a period of time, but then they are struggling to take those initial steps to go back, and actually that can lead to a downward spiral rather than the recuperation that I think people aspire to when initially they might take a bit of time off work. And it's really important that the welfare system isn't just a safety net that people can fall onto when they hit hard times, but it's a springboard that helps them back into work.
Thank you. And I'll just quickly move on from this because I know others need to get in. Just to turn back to reform of the NHS and kind of scrapping NHS England. As part of the reforms, how are you going to make sure that these reforms are used to strengthen both the clinician and the patient voice and centring that at the heart of what you do?
Yeah, so as people will see in the 10-year plan when it's published in June, there is a big emphasis on not just devolution of power from national leaders to system leaders or provider leaders, but devolution of power so that clinicians feel like they are more empowered to innovate, to do things differently, and then crucially power in the hands of patients as well. And there will be a number of ways in which we will achieve that outcome through the 10-year plan.
Thank you. I'll pass back to you, Chair.
Thank you, Alex McIntyre.
Thank you, and thank you all for appearing today. Secretary of State, you've mentioned several times today that there's lots of duplication. What exactly is duplicated between the department and NHS England?
Well, bearing in mind that there will be people who are working in these teams, so I do not want the examples I give to be seen as a reflection on the quality of their work or dedication to their jobs, because that's not the case. But there are some obvious examples. You've got 2 HR departments, 2 finance departments, 2 communications departments. I mentioned the duplication we're seeing in terms of policy and strategy functions, and then you start to go down the system. You look at NHS regions, you look at ICBs, and then you look at the different regulators and the regulatory landscape, and your lines of accountability and focus of work begin to look either blurred or worse still like Mr. Messy in terms of the kind of the number of lines of accountability and the amount of duplication. So I think we'll be Dr. Penny Dash, prior to her appointment as chair of NHS England, was already doing some work on the regulatory landscape, but we'll be looking at all of these things in that context of trying to make sure that nationally we provide the thing that is most important in a system of this size and scale, which is clarity, followed by the tools that people need to do the job.
And why do you think that duplication's been allowed to happen historically?
I'm tempted to suggest you should invite my predecessors in front of the committee. I would certainly tune in for that episode. Well, look, I think a number of reasons. I think in terms of thinking about the 2 organisations, there's certainly quite a lot of what I'd call man marking going on between the department and NHS England. So you would have, for example, there are 2 electives teams, and I can happily pick out electives as the example without offending anyone in those teams, because actually I've often cite the electives team as a team that works really effectively well together. But notionally those 2 teams have been set up for NHS England to deliver elective performance and elective recovery, and the department's a man mark. Now, thanks to the one team approach we built, actually the team is working much more effectively like that, and we've got a team of doers rather than a team of doers and a team of checkers. But you can imagine across all of the different areas of health and NHS activity just how widespread that kind of duplication is. As I say, there's a policy and strategy function that now exists throughout NHS England, filled with, by the way, some extremely bright and capable people, but that's not what NHS England was set up to do. So you'd have to ask my predecessors and Jim's predecessors and NHS executives over the years, but I think it's a natural tendency to expansion in the state. I think it's a natural tendency to empire building. I think it's a natural tendency when something's not going right. Let's think, and just think about the broader regulatory landscape. If there's a problem, you introduce a new regulation. When that doesn't work, you introduce some more regulation. And when that hasn't worked, you might not only introduce a new regulation, you might even introduce a new regulator. And if you look at the way in which over more than a decade the health and social care landscape has evolved, we've got far too much duplication. I think that's partly how we've got to this position and why we need to call time on it.
Sure. And the number that's been bandied around is that there's going to be a 50% reduction in workforce. How has that number been calculated? As I say, we know that there is duplication across NHS England and the department, and so we've taken into account a few things. One is where we think there are duplications of functions. Secondly, where we intend to devolve more power and responsibility, and therefore, in the spirit of what I said to NHS providers, if you're giving power away from the centre, you should necessarily shrink the size of the centre. And thirdly, to demonstrate intent and direction to the system as a whole and the seriousness of our intent and purpose. So we're about to embark on this process, as I say, in terms of the transformation team being established. The work is now well underway on that front. Whether or not we land on 46% reduction or 52%, we will do through careful design and deliberation and consultation with staff in the way that you would rightly expect us to, in the spirit of not only treating people fairly, but making sure that the setup that we have is the right setup for the longer term. So we've announced a big bang change in terms of how we execute this. We're proceeding in a careful, considered way. So even though the change itself is a radical change and a radical reduction of the centre, we are proceeding in a kind of considered and thoughtful way about how we execute that plan. So it's a direction of travel rather than a hard and fast target.
Yeah, we've been very clear we want to reduce the size of the centre by 50%. I'm not kind of so dogmatic that if we ended up just below 50% or just above 50%, that I would be feeling like we failed one way or another. But I think that direction is really important. It's also important in the context of the financial savings as well. And I sort of kind of make no bones about the fact that one of the objectives of this exercise is, yes, to ensure better clarity and decision making from the centre nationally, but it's also about freeing up hundreds of millions of pounds that can be deployed into frontline services, and I think that is a good thing to do.
You preempted my next question, so that's a perfect segue. So in terms of the savings, you said that they're running to the hundreds of millions. In terms of just, and presumably that is in removing some of that duplication directly, but what are some of the other costs that there are to the taxpayer in terms of the way that the department and NHS England are currently structured?
In what sense?
So in the sense of kind of opportunity costs, or the fact that you've got people who are man-marking, whereas actually if they were doing that, there would be an opportunity cost there.
Yeah, I think that is exactly the right framework for this, exactly the way in which we're thinking. If you can free up hundreds of millions of pounds and deploy that resource to the front line to invest in, more frontline staff, making sure we've got the right care in the right place at the right time. I mean, not only are you going to deliver better care for patients, you're going to deliver better value for taxpayers. And that is, in a nutshell, what is driving the government's whole approach to NHS reform. It is a conviction that we're not spending the money as effectively as we could, and that is coming to the detriment of patient care and outcomes, and it's also coming to the detriment of taxpayer value. And when you look at our growing ageing society, rising levels of chronic disease and rising cost pressures, if we do not act to bend the curve of cost and demand and to spend the money that is already going into the NHS as effectively as we could, then you risk busting the NHS's finances and putting into serious jeopardy the NHS model and those founding NHS principles of a publicly funded public service free at the point of use. We are unequivocally committed to those values as a government and as a party. We are absolutely determined to make sure that those equitable principles that were there at the NHS's foundation and saw us through most of the 20th century not only survive and thrive in the 21st, but that does mean reform. That's why I think it's existential, and why in opposition and now in government I've emphasised consistently the importance of not just investment but reform, which we are now demonstrating through our actions in government, not just the words we said in opposition.
And so, just to follow on from that, I mean, it's really reassuring to hear that those savings will be making their way to the front line. I guess two follow-up questions from that. One is, you know, the hundreds of millions in percentage terms, in terms of the overall spend of the department, is relatively small. So what impact do you think that the savings here will have on the front line? And I guess, you know, from a personal perspective as the MP for Gloucester, when can Gloucester residents expect to see kind of the benefits from that investment on the front line? We've obviously had a reduction in waiting lists already. However, you know, when can they feel that and see, you know, find that it's easier to see a GP or get a dentist appointment when they need one?
Yeah, so I'd say a couple of things. Firstly, it really, that is not a criticism of your question, by the way, it really boils my blood when people say, oh, but it's only hundreds of millions of pounds of savings, is it really worth it? I think one of the cultural problems with the NHS and the cultural problems with you know, a department that has a budget of the size that we do, now in excess of £200 billion, there is a risk that because we deal so often in the billions, that we lose sight of the hundreds of millions and the millions. And you ask any one of my cabinet colleagues what they could do with hundreds of millions of pounds, or how much of a greater proportion of their departmental spend it might be compared to my department. And then also you ask our constituents, the taxpayer, like what they would do if they had more money in their pocket, and some of the marginal decisions that families are making in the supermarkets between what they put in the basket and what they put back on the shelf. Like, I think there is just such a bad culture when it comes to treating taxpayers' money with respect and spending taxpayers' money as wisely as the mum or dad in the supermarket that's put something back on the shelf that they really think they need in the fridge back at home. So given we are asking people to pay more in taxes, the tax burden in this country is high, we owe it to make sure taxpayers' money is well spent, and I owe it to taxpayers and to my colleagues in government to make sure that our budget is always well spent and we treat taxpayers' money with respect. And to your constituents in Gloucester, well, I hope that if nothing else, in the last 9 months, against a backdrop of, I think, unprecedented anxiety about the future of the NHS, and also rock bottom trust and confidence in politics and politicians, I hope people have begun to see in the last 9 months that waiting lists are beginning to fall, that the numbers of GPs are beginning to rise, that day by day, week by week, step by step, we have been putting the NHS on the road to recovery. I wouldn't overclaim we're on the road to recovery, but the road ahead is long. And we know that there is still an enormous amount we need to do, but we are delivering the promises we made, we are beginning to improve services, and that is a direct result of the decisions that we've taken since we were put into power. And so I'd say change has begun, but the best is still to come.
Thank you. And final question from me. I appreciate you won't be able to comment perhaps specifically on this, given the consultations will be ongoing, and we want to prejudice any of those. But we saw reports at the weekend that the redundancies and the packages that might have to be paid to staff may end up costing the department up to £1 billion. I guess, again, a two-parter. Firstly, do you recognise that figure? And secondly, do you anticipate, or has there been an assessment made of what the costs of this transformation programme are going to be, and whether that will impact some of the investment we can make as in our services as a result?
Obviously we won't know the precise numbers until we have kind of confirmed what the ultimate size and shape of the organisation will be, the impact in terms of headcount and how much it will cost in order to treat people fairly whose jobs are at risk and then whose jobs that are not carried forward. But I didn't think that was an unreasonable ballpark figure. And I would kind of justify that cost on the basis of the fact we will more than pay for that in terms of the savings that are achieved year on year. And I think one of the reasons why we end up sometimes with a bloated state is because people start to look at some of the costs of change and transformation and think, oh, we're not going to bother. This is in the too difficult box and we just can't afford to do that as a country any longer. I would argue that we should have done this a long time ago.
Can I just add to that? So there will be a business case. It will have to demonstrate a payback. It's public money. You will have to have this agreed with Treasury, etc. And as Secretary of State said, there's a really, on the face of it, a really significant, quite rapid return on investment, if you look at it as an investment. So it shouldn't put us off. It has put us off in the past for making these kinds of changes. It's part of why the financial position is as tight as it is now, and we've got to break through that.
Where is the money coming from in year?
So we've just started a discussion with Treasury about how the redundancy costs are managed, but that's not complete yet.
Oh, so it may not come from within budget, the current allocation?
Subject to discussion with the Treasury.
Thank you.
Whose servant I am.
Lines between have been read. Thank you. Joe Robertson.
Thank you. Good afternoon, Secretary of State. So NHS England is disappearing. ICBs are definitely staying.
Yes.
And they will be central to commissioning and developing what you call good neighbourhood health services, and central to realising the ambitions in the 10-year health plan.
Yes.
So why are you cutting their operating budgets by 50%?
Because we're going after waste, duplication, inefficiency, and if we're asking ICBs to focus on strategic commissioning, then by definition that also means asking them to stop the duplication, which I think has been allowed to build up unnecessarily and avoidably.
And can I just add to that as well? On the variation on pay spend per ICB per head, it ranges from £49 to just short of £21. So in throughout this, as a kind of response to one of your questions earlier on, what we're trying to go at here is the variation, and for this to be more fair and more equally distributed and maximise the resource to the front line.
Can you show us the analysis that helped you arrive at 50% as the right level of cut to their operating cost?
Well, it was I think about, as I say, reducing the duplication, reducing the inefficiency, and also bringing the NHS under financial control and making sure that we've got the right spend in the right place, which is closer to the front line.
So for ICBs, you're sure the figure is about 50% cut? You're sure that's right?
That's what we're going at. Those are the plans that will be coming in, and obviously we'll look at plans that come in on their merits.
And the extent of the variation gives us confidence in that as well. So if you look at the variation in spend, there is very little correlation between performance outcomes and impact there as well. But also, just coming back to this, how the numbers were derived, we needed to move more quickly, and we needed to send a signal that this needed to be dramatic, because we're just moving very slow, improving slowly. And I think what we're trying to communicate is we need a very much more rapid change and more significant change to deliver what we need to in the future.
So, Jim, obviously, boss of NHS England, you just last week wrote to health leaders saying we will share with you soon what we think is a reasonable running cost per head of population for ICBs. But hasn't the Secretary of State just given you the answer? It's 50% of the current cost.
Yes, but because of the variation between ICBs, what we didn't want to do is have a blanket 50% everywhere, because that would just continue to bake in the variation. So we've calculated what a cost per head would be. So some will save more than others to get back to a more level playing field. That's being shared informally with their colleagues in the service, and that's being developed currently before we land final numbers for them.
So some ICBs will be asked to save more than 50% and some will be asked to save less?
Yes.
And will that be based on their performance so far, their health outcomes?
It's addressing the overall running costs and trying to get everybody to the same amount of running costs per head of population.
Will demographics be taken into account?
There's a good point there on the formula generally. We're going to get back to the formula, move the allocation of resource away from the pattern that's been developing over recent years back to the formula. This running cost formula is simply cost per head to run those ICBs, where I don't believe there's a strong argument that demographics is a significant driver there.
Do you know what's in the 10-year health plan?
I do. Well, certainly the draft, but obviously it's subject to not only internal kicking of the tyres, but I also need to take it to colleagues across government and make sure that they're happy with it, not least the Prime Minister. So, but yes, in terms of where I am on the 10-year health plan, I'm very clear about where we're going.
And when will ICBs see what they need to see in order to decide how to save money?
Well, that work is already well underway, and as Jim has already reported, plans will be sent in and will be considered on their merits and their viability. But I've been very clear about, right back to the NHS provider speech I gave towards the tail end of last year, we want ICBs to focus much more on strategic commissioning and making sure that we are delivering the kind of the neighbourhood health services that people need to reduce demand on secondary care, to make sure people get the right care in the right place at the right time.
Will any NHS England powers be coming down to ICBs, or is it all about powers going up to the department?
No, I mean, look, we want to actually devolve power, resources, responsibility from the centre closer to the front line, and indeed at the front line. Look, I can totally understand why when we announced the NHS England would be abolished and rolled into the department, there was a kind of cautious welcome from some quarters that said, look, totally get the case on duplication, and this will be a good thing if that is also about devolution and not simply about concentration of power in the hands of a Secretary of State, let alone this Secretary of State. And so to reassure people, this is very much about devolution and not about centralisation, quite the opposite.
If powers are coming down to ICBs, how are they expected to deliver that with half the amount of money, and some of them with even less than that, given that you're prepared to have variation across ICBs?
And to provider organisations, and rationalising the regulatory landscape and making sure that we're measuring the right things in the right way, doing quality assurance and improvement in the right way. There's devolution of power not just to ICBs, but also more freedoms and flexibility closer to the front line across the range of NHS provider organisations.
And it's just on that as well. The intention is to move more towards a rules-based system where people can understand the rules and comply with them without being in central approval mechanisms for lots of things. So it's been a natural thing that's developed over the last few years, very more centralised processes, and this is about trying to reverse them. So those things don't need to be replaced anywhere else in the system. We'll remove the approval process, but replace them with a clear set of rules and criteria.
Are you going back to foundation trusts, basically?
There are similarities in a lot of the approaches, and in all of this...
Regulator that went with them. I mean, I've mentioned a couple of times now the regulator. So are we looking at a new regulator in the similar model to what we saw before?
In terms of monitor, I mean, no, not necessarily. No. I mean, and these are all... these are all subject to where we will land in the 10-year plan. But I believe fundamentally in more freedom, more flexibility for frontline system leaders and provider leaders. Absolutely. Do I think you need to make sure that comes with appropriate quality assurance and accountability? Certainly. Do we have a far too crowded regulatory landscape at the moment? I think certainly.
We know that.
And Penny Dash will be having more. That report is coming shortly. But I definitely want to see more freedom and flexibility for provider organisations. I think the one thing I would just kind of add as a cautionary note, not least actually just as a point of reassurance to the committee, to Parliament, to the system and to the public, I'm really proud of what the last Labour government did in terms of lowest waiting times, highest patient satisfaction in history. But we've also got to make sure we get the balance in the right place, especially on patient safety. I always kind of keep in mind the lessons of the Francis report, I always keep in mind some of the patient safety scandals that we've seen arise since then. And so under successive governments, we've seen real shortcomings in patient safety, to put it mildly, frankly, in some cases. In some cases, we've seen horrifying failures, and the worst meetings I've had in the last 9 months have been with victims of various NHS scandals, whether maternity scandals, mental health scandals, and so on. So you've got to make sure that patient safety is at the forefront. But I say that by way of reassurance, so that as we are doing more freedom and more flexibility, we are not losing sight in that context of patient safety, accountability, quality assurance and standards.
One of the criticisms, I think, of ICBs broadly across the board is the lack of representation or lack of strength of representation for primary care, community care, and the interests of social care. Will you bring about any reforms to strengthen that representation on ICBs?
Well, I think there's an interesting governance question. I mean, I do think you want on any board a range of experiences, perspectives and insights to make informed judgments. I kind of always kind of resile a bit when people start demanding kind of a sort of a representative kind of structure where you have got to have like a person from this background or that background or the other background. I think what you need is a range of skills, experiences and perspectives. But certainly if you look at what we've done in the context of Jim's transformation team, you know, I think one of the really encouraging things that Jim has done with his team is in the context of the National Medical Director. Actually now we've got two, one for primary care and one for secondary care, and I think that was a really good innovation. And I think sends, also, as well as being of practical use, which is the most important thing, is it also sends the right signal. So I would definitely expect ICBs to have on their boards people who have a good understanding of the system that they are responsible for leading.
It might help your shift to move from acute to community if ICBs had better expertise and representation of what good community and GP primary care look like.
Well, I would certainly expect any board of any ICB in the country to have people with skills, experience, knowledge and insight of the breadth of the system that they're responsible for leading.
Could I just turn to dementia? So dementia was taken out of the NHS England's planning guidance at the beginning of this year, so it's not mentioned at all. Will you put it back in the planning guidance for NHS England, Department of Health and Social Care, whichever organisation produces that planning guidance for next year?
No. I totally understand why, and not just in relation to dementia, but on a number of other fronts, we had voices, particularly from the voluntary and community sector, saying, well, hang on a minute, something that we care about has not appeared in the planning guidance. I just genuinely think that one of the problems that we've had with the planning guidance is it has become overloaded with every campaign ask, and it sort of starts to turn into, you know, the sort of the common analogy is like the Christmas tree, where everyone sort of hangs everything on. But actually, I think it's more like Buckaroo, where the more and more you hang on it, at some point the thing just kind of buckles. And
Dementia's the biggest cause of death
where
in the
we've been. And certainly, as you've seen in the government's health mission, we want to reduce the number of lives lost to the biggest killers. You're absolutely right about dementia, and that's why, you know, in terms of things like dementia research and dementia treatment, that continues to be an area where we are making progress and will continue to make progress over the course of this Parliament. Just because something is in the planning guidance doesn't mean it's not happening. Just because something isn't in the planning guidance doesn't mean it's not important. But in terms of we've got to get used to this new world if it's going to work. Like the idea that we just do top-down command and control on every single front for every condition is not a way to lead a health system.
I welcome those comments that said I don't welcome you not putting it back in the planning guidance. It's such a significant document for where the NHS is heading for the year in advance, that not to have the biggest cause of death in the UK in that document for the first time in ages seems to me a tragedy for those living with dementia. Could I finish by asking whether you would like to see a national prostate cancer screening programme for men at high risk of the disease?
I would like to see that, but, and this is such an important but, decisions in this area do need to be evidence-based and evidence-led, and that's why we have a National Screening Committee. So I've asked the National Screening Committee to look at this, and they are. I think there is an even more compelling case around groups that are at higher risk of prostate cancer. But ultimately, and I think this is where as politicians, like, we have such a responsibility to kind of sometimes resist the temptation to sign every petition or to sign up to every campaign. We've got to make sure that decisions we make are evidence-led and evidence-based. So, sure, I would like to see, screening in this place, not least because, as I was questioned on this on BBC Breakfast this morning, I can go on BBC Breakfast as a politician, as a health secretary, and say, great news, I'm backing Chris Hoyer's campaign, I'm doing what everyone wants, and people will kind of say, great, really good to see the government doing this. But I'm only going to do that if the evidence base suggests that is the best use of a valuable resource, and certainly constrained resources, which I know is not always the most popular answer, but I think it's the right answer. And I think all of us as politicians kind of need to show that restraint and discipline sometimes of not just signing up to the latest campaign unless the evidence tells us this is the right thing to do.
Thank you. Danny Beals.
Thank you very much, Secretary of State, for your answer so far. You've in your letter to the committee previously kind of outlined the need for legislation. It's been discussed already, primarily to formally abolish NHS England, which was established by legislation. I just want to press you a bit more on the timing of possible legislation. Are we likely to see it in the next King's Speech?
This is a sacking offence now. If I say it will be in the next King's Speech, it is His Majesty's speech, so it's certainly not for me to pre-announce it. And I'm definitely not going to fall foul of the Leader of the House of Commons or the Leader of the House of Lords by saying what I would like or not like to be in the King's Speech. It suffice to say that in order to conclude this process in its entirety, it will require primary legislation. And I've already begun to socialise that issue with business managers, as you would expect.
Diplomatically done. So we know that will be part of the legislation, but what other aspects of change to the system are you considering being part of that legislation, as well as just formally abolishing NHS England?
I've no doubt, and this goes to some of Mr. Robertson's questions. One of the challenges we will have as a bill goes through Parliament is I'm sure lots of people have got lots of ideas about NHS structural reform.
What would you like to do? Are there issues that you...
Well, I think it'll be more my job, rather than adding to it, I think it'll be my job trying to fend off various attempts by different hobby horses and campaign groups and corners of Parliament to try and hang more reorganisation onto this bill. So I'm going to do my best to proceed in a very disciplined way to make sure that the bill delivers this change rather than every other change that people might like to see at every other level of the system. We don't want to do Lansley Mark II.
I note the point, the desire to resist reorganisation of the NHS, but we kind of are undergoing now a major reorganisation of the NHS. So is it not the case, having kind of opened the box, so to speak, of NHS reform, is it now not the opportunity to finally grasp some of these nettles that haven't been grasped? Obviously, there's the Baroness Casey review taking place of social care. My colleagues kind of touched upon the fact that ICB structures are very much focused on healthcare, but not integrated with decision makers on social care or on public health, as in local authorities. ICPs are kind of very loose bodies. There isn't formal budget sharing or shared decision making. Are those the sorts of issues that we should be looking at as part of legislation which now is going to have to come before the House?
Well, there's certainly lots of specific duties of NHS England that would need to be dealt with through primary legislation, commissioning services, oversight of ICBs, oversight of trusts and foundation trusts, provider licences, the digital and technology products and services, the data to support the health system, planning of workforce, recruitment, education. So there are lots of things which are defined in statute as roles and responsibilities of NHS England, which we want to transfer to the Department of Health and Social Care. And look, if people have got ideas and particularly compelling examples of things where they think the law is out of date or the law's getting in the way or the law is out of touch, by all means, we're open to those representations, but I would urge parliaments to resist the temptation to do unnecessary reorganisation. And your point, Danny, about the opportunity of reform bill is why I thought very carefully before opening this box and going in this direction.
But there's been discussion of a national care service. There's
I think I'm doing my best to put you off hanging any more things on this bill, and I'm worried I'm already failing.
You know, in your own comments, talked the importance of having one HQ for health. Could you not argue that having one HQ for health and social care locally and nationally would be an important step forward in reducing overlap and regulation? And is this bill an opportunity to do that?
I think this is where, if you'd asked me when I was appointed Shadow Health and Social Care Secretary a few years ago, what are your thoughts on where social care should sit? Should it be folded into the NHS and have a national health and care service? Should it remain primarily with local government? I would have said I was open-minded or agnostic. I am now even more strongly of the view, as the Secretary of State for Health and Social Care, that social care has different roles and responsibilities than the National Health Service. And of course, in that kind of Venn diagram, there are big overlaps between the two, and there are relationships between the two, which is why there'll be some reference to social care in the 10-year plan for health. But it is a different type of service, meeting different types of need, which are not all about treating or preventing ill health, but it's about promoting dignity, independence, quality of life, and a range of caring functions, which I think not only are not delivered by the NHS today, but are better delivered and commissioned through local government than if they would be through the NHS. That doesn't mean there can't be more integration of health and care services in some cases. It doesn't mean that the NHS can't or shouldn't spend more of its resources through social care to deliver better outcomes for patients and better value for taxpayers. But I think these are distinct services. They have an interrelationship, but I wouldn't want to see the NHS and social care merged.
Thank you, that's clear, thank you. So in terms of the functions that are currently performed by NHS England that could be transferred to the department, in your early answer you talked about these kind of enablers of the whole system that are crucial at kind of national level, I inferred from that. So procurement, data and AI, kind of digital infrastructure, potentially life sciences, drug procurement. So you're envisaging that those and national enablers will simply move from NHS England to the Department for Health? And do you envisage other broader changes to the national landscape? Obviously, we talk about NHS England and the functions moving to Department of Health, but obviously there's other national bodies and infrastructure, so NHS Property, the CQC, MHRA, the list of acronyms goes on, longer than your arm. So as well as changes into functions into department, are we likely to see functions move or shift within the broader landscape nationally?
Yeah, well, you've heard what the Prime Minister and the Chancellor of the Duchy of Lancaster have said about the number of arm's length bodies. We're committed to reducing them overall as a government, and I'm certainly committed to reducing the number of arm's length bodies attached to my department during my tenure as Secretary of State, and we've started with the biggest. I think for that reason, we are treading carefully in terms of looking at the ALB landscape in the Department for Health and Social Care to make sure we're doing two things. Firstly, not missing any opportunities. If we think there are other ALBs that should be folded into the department, I wouldn't want to miss the opportunity to do that now at the expense of doing another integration down the track. If we could effectively do more than one now, and that's the right thing to do, then we should seek to do that. The judgment we have to make, though, before taking those sorts of decisions is making sure that we're not biting off more than we can chew and not trying to do too much reorganisation at the same time. And I think there are some obvious ALBs where I think because I think that this is important to bear in mind in the discussion about ALBs, there are and will always be arm's length bodies for good reason, and there are and will always be arm's length bodies discharging responsibilities on behalf of government and the public because they are better set up to do that, or necessarily set up to do that, as arm's length from government. So we shouldn't assume that all ALBs are bad, and there are some obvious ALBs that I wouldn't want to get rid of. But this morning I'm resisting the temptation to say, well, yes, but we're obviously not going to get rid of X, Y or Z, because in omitting to reference every other ALB, I might end up causing unnecessary anxiety amongst people.
We've heard that there's a general view that they should be looked at and assessed.
We're looking at this strategically, but as I say, I'm just really conscious that we're doing something quite big now, and I don't want to
see
bar
any
more than we
new
can.
bodies established nationally. As you said, there's a desire to reduce them, so on that basis, we won't see any new national bodies created.
Well, I definitely want to see the number of ALBs reduced during my time as Secretary of State, and therefore there is a very high bar for someone to persuade me that a new ALB is required.
Just lastly, NHS England is a source of significant clinical leadership, clinical expertise. It hosts specialist clinical networks of various sorts, has national clinical directors. What's the future of those? Are they likely to shift to the department? Are you seeing a more local leadership model rather than national coordinated clinical networks and specialisms?
Well, I mean, we've already got clinical leadership, across the NHS, quite rightly, in system, amongst the system leadership and provider leadership. And I think we will always want to make sure that there is good national clinical leadership as well. I've got one of those national clinical leaders sat to my left. There are many others who in the future will be housed in the Department for Health and Social Care, but we have got to make sure we have that clear distinction between political leadership and official civil service leadership of the system as a whole and clinical leadership. It is one of the reasons why, despite political pressure to intervene politically, whether, for example, in relation to implementation of the CAS review or in relation to a number of reorganisations of particular services or pathways that providers or systems have proposed, I have resisted calls to intervene politically. And, that is because, I believe in clinically led and evidence-based decision-making. People do not want, for understandable reasons, the Secretary of State for Health as a politician making decisions that rightly belong with clinicians. In fact, I see it as part of my job to protect clinicians from political interference.
Those clinical leaders at a national organisation presumably drive clinical
I rely all the time on good clinical advice, because there are occasions where the Secretary of State has, in statute, powers to intervene. Or powers to take decisions. And there are bills going through Parliament presently that propose to give the Secretary of State more powers in this respect. And it is really important that Secretaries of State are making decisions based on good clinical advice, evidence, and crucially protect clinicians from political interference.
In terms of highly specialised services, again, NHS England has traditionally taken a lead. There's been some movement back towards a local level. But many patients with highly specialised conditions sometimes worry about local leadership, and that ultimately means local variation. If your ICB don't prioritise your specialised condition or don't have a specific high population of that specialised service in your locality, that will mean maybe the service isn't there, and that national service specifications have ultimately led to a higher bar for quality for specialised services. How do you envisage specialised services evolving? Is there still going to be a role for national leadership and expectations being set? Or is it purely going to be local decision making?
No, I think there still is a national role in relation to specialised commissioning. But again, you've got to get the balance right. And this is something we are kind of considering very carefully in the context of the 10-year plan, because we want to make sure in terms of how we set the system up that we're taking the right decisions in the right places, and clearly in lots of cases you want more freedom, more flexibility, more innovation at the front line and at system level as well as provider level. In other cases it will be more desirable, more effective to have national decision making, clinically driven, clinically led, but those are the sorts of edge cases and tensions we're considering in the context of the 10-year
Thank you,
plan.
Secretary of State. And just lastly, the shift of this clinical knowledge and expertise and capacity, obviously this is evolving, but how will we ensure that work currently underway on specialist areas, so the National Cancer Plan, the HIV Action Plan, which are commitments, and other areas, how do we ensure that in this time of change and of flux for expertise and capacity, that work is not diluted or delayed or ultimately sacrificed as part of this broader change?
I'll say a couple of things. Firstly, I'm left in no doubt by the Prime Minister and the public that regardless of the reform agenda we're pursuing to deliver better outcomes for patients and better value for taxpayers, that can't be an excuse for not delivering consistent year-on-year improvements in NHS services on the manifesto we stood on at the election and the plans that we have committed to. And so I've got a sharp eye on delivery. One of the reasons I'm delighted to have Jim sat to my right is one of the reasons we've appointed Jim as the Transformation Chief Executive of the NHS is because he has that combined experience of organisational change, transformation and improvement, and also a track record of not just good financial management but good delivery, particularly on elective recovery. So my eye is very firmly on the ball when it comes to the delivery of improved outcomes for patients. I see what we're doing in terms of the wider system change and organisational change at the top at NHS England as being in pursuit of improved services for patients, not being contradictory to or a distraction from. If we get this right, we will deliver better value for taxpayers and better outcomes for patients. And that's why, as we've embarked on this process, we've sought to learn the right lessons from where previous reform agendas have and have not been very successful.
Thank you. We are failing miserably at keeping to time, which is my fault. So we're going to go now to Josh Fenton-Glynn.
Hi, Secretary of State. I'm going to talk a bit about NHS Digital and the NHS workforce more generally. It won't surprise you that the NHS England workforce is of particular interest to me, being a West Yorkshire MP, and the NHS England has a particularly large footprint in West Yorkshire, effectively with a sort of second NHS HQ in Leeds. So I think everyone on this committee is persuaded by some of the logic of the changes that are being made, but I'm also a bit concerned about some of the skills that we might lose, particularly around NHS Digital. So could you give me some assurance that the skills, particularly around that kind of digital infrastructure piece, which really needs a lot of change, but we need some skilled workers to do that, will remain and ideally will remain in West Yorkshire?
Yeah, I'd say two things about the functions and skills specifically, and then Leeds. Firstly, we are still in the foothills of one of the most exciting revolutions taking place in the world, which is the revolution in life sciences and medical technology. As the Prime Minister announced this week with the establishment of the Health Data Research Service, we want the UK not just to be benefiting from that revolution, but actively driving it. We have a competitive edge in this country which is in danger of being lost. We will only achieve it if we've got the right policy direction, but also the right team and skills to deliver it. And whether it is on the security and integrity of the NHS's digital systems, the rollout of new digital capabilities, and our ability to marry the best scientific minds in this country and around the world with our National Health Service, we will need more of this capability. We will need people with the best skills. And so that function of NHS England, which is driving that digital transformation, breakthroughs in life sciences and technology, as well as big productivity improvements and gains in the NHS, that function remains extremely important and will be part of the new department. But those skills, that functionality, we absolutely do not want to lose. And secondly, I'm absolutely committed, and this government is absolutely committed to Leeds, not just in terms of the department's base in Leeds, which is effectively, our headquarters in Leeds. And I think that over a number of years now has been part of a really strong ecosystem for health and science in Leeds. And I know we often talk about the Oxford-Cambridge arc, big part of the government's plan for growth. And with London, we've got a really strong science powerhouse here in London and the South East. But with respect to my alma mater and the chair's city, and the city I represent and live in here in London, we've got some brilliant science strengths outside of London and the South East, particularly in Leeds, but it also applies to places like Stevenage, Liverpool. So this department is absolutely committed to Leeds, absolutely committed to the capability that we have in Leeds, and being part of that wider Leeds health and science ecosystem, which I think is a big strength, not just for West Yorkshire, for our country.
On West Yorkshire, obviously, we've got the Health Innovation Village in Leeds. There's some anxiety about the delays in the rebuild of the hospital, and I understand why that's happened. But yeah, can I have the assurance that we're going to work on an NHS which is a good place to invest for, and a good place for life sciences and that kind of work?
Absolutely, and look, I had a deputation of the Leeds Mafia to see me / ambush me here in Parliament only recently, which was a delegation of not just MPs from the city and the region, but from the NHS Trust, the City Council. Tracy Brabin has been, as you would expect, banging the drum very loudly for her region and its science base and health strengths. So I think it's really important for me to signal very clearly not just our current but our future commitment to Leeds and to West Yorkshire. I actually think there are opportunities for us to leverage in more partnership, particularly with the life sciences sector, the medtech sector, and to look at what we can do together to invest in and build that really strong health and science footprint in Leeds for the benefit of not just West Yorkshire but for the country. And in terms of the hospital, I will take this as another representation in the context of the new hospitals programme.
And just moving back to that workforce point, what's the timetable for the NHS workforce plan now?
Well, we are reviewing the workforce plan in the context of not just the 10-year plan, but frankly the blindingly obvious problems that we've got in the NHS today in terms of workforce planning. I think some of the complaints that we've heard from not just resident doctors, but resident doctors in particular, about their future career prospects, the lack of specialty training places, and some of those bottlenecks are really well made. So we will, following the publication of the 10-year plan in June, there'll be some technical work underway to make sure that we've got a long-term workforce plan that we can have genuine confidence in and can survive the transition from one Secretary of State to the next, which I'm afraid to say the current workforce plan has not.
And the other thing, obviously, it's got a lot of change for NHS England and NHS Digital and various parts of the structure of the NHS. How are you going to ensure that the culture for people working for the Department of Health is going to be anything decent after they've seen a lot of their colleagues moved out of jobs and seen that much change?
Yeah, so I'd say a few things on this front. Firstly, and this again, why we don't take these decisions lightly, I am very conscious that there are a number of people now who are anxious about their jobs and their futures. And I'm genuinely sorry about that because I don't want people to have to worry. And we would not be doing this unless we genuinely thought it was in the public's interest. We are, in terms of how we're handling the next steps of this process, proceeding with the degree of care and consideration and fairness that you would expect us to treat people. We're engaging with the staff trade unions, and we are keeping staff informed as the Transformation Board does its work so that people know where they stand. And as I said earlier, in an ideal world, if I was leading a restructure in any other walk of life, I would have put my transformation board in place, had a look at the organogram, the job descriptions and functions, and I would then at that stage make the announcement. Unfortunately, at the world in which we live, the moment I commissioned that work to put together that plan, it would have immediately leaked and I'd be reading about it in the HSJ. So we've tried to proceed in a way that is fair and transparent to staff, and also meeting our obligations to Parliament and to the public. So the headcount reductions were known ahead of the Prime Minister and I announcing the abolition of NHS England. But I don't want to pretend for a moment or minimise the fact that that will have come as a shock. And that even where there are people in the department and the NHS England who recognise what we're describing and the problem we're trying to solve and the impact we are driving towards, if your job's at risk, it doesn't make you feel happy, even knowing that that's the direction. So we're proceeding with that in mind. I must say, regardless of the anxieties that people feel, my sense is that people are continuing to go about their work with the same professionalism and commitment that has driven them to now. So we'll proceed on that basis. The final point I just want to say to your point on culture, it is crucial that when we bring the two organisations together, that we have one team, one culture, better ways of working, and an environment where people feel happy at work, fulfilled at work, and productive at work. So I think you don't just build culture by imposing it from the top. There'll be lots of work done with staff to make sure they feel like they are part of that one team approach.
Thank you, Secretary of State. And just because you mentioned unions, I just want to put on record that I previously worked for the Public and Commercial Services Union, just to put that interest out. But thank you.
Yes, I should also declare I'm a member of Unison GMB and Community.
Thank you very much. Andrew George.
Thank you. What lessons have been learned from previous reorganisations? I mean, I was around at the time on the government benches opposing all the way through, I have to say, to the bitter end, the Lansley reforms, which David Nicholson described as could be seen from outer space, as we'll all remember. But if you were looking at those reforms and the major restructuring that happened then, I mean, what if you like one lesson would you say you've learned from that which you're seeking to avoid on this occasion?
Proceed carefully, even if you're acting radically. So coming into office, we came in with a whole set of things we wanted to do and where we've hit the ground running. We're beginning to see some of the fruits of that with falling waiting lists and increasing GP numbers and the impact of the decisions that the Chancellor made in the early weeks of our time in office, as well as at the budget, which will begin to kick in the new financial year. I was also criticised at the same time because we said we were going to consult on our 10-year plan. And I came in sceptical and actually resistant to doing structural reorganisation. And I would strongly defend that approach and those instincts, because I think that the challenge, as I kind of saw it with the Lansley reforms, was that he had done a huge amount of work in opposition, come into government with a ready-made reorganisation and a plan that was then imposed in a very top-down way, and where even when people were expressing criticisms and concerns, was just sort of steamrolled through. And I think David Cameron even realised what Andrew Lansley was up to. So what we've done is a different approach, which is consult on our 10-year plan, engage extremely widely, so that when we publish a 10-year plan, I think it should be broadly welcomed. People will understand the direction, understand the part they play in it. And in terms of the changes I'm making to the Department NHS England, that's been done after consideration of seeing how things are working in practice. And in terms of the next step of the process, we'll be consulting and engaging on how the
How disruption that this is going to cause is not going to distract you from the delivery of the 10-year plan and indeed onward to patient safety and improvements in patient services?
I think I'd say two things in response to that. One of the interesting things in the aftermath of the announcement about NHS England, aside from one or two people who, my favourite one was the anecdote of someone who was in A&E, sat next to someone who turned to them and said, enjoy this while it lasts, because Wes Streeting's getting rid of the NHS. Because I think they had taken the abolition of NHS England as the abolition of the NHS, and for the avoidance of doubt, so long as I'm the Secretary of State, the NHS is here to stay, publicly funded, public service free at the point of use. But I actually think that one of the things that patients and NHS staff have in common is frustration with what they see as layers and layers of bureaucracy. And I think the public will be pleased to see that we are going after that and looking to redeploy more resources to the front line, which is where it can really make a difference. And my focus and the Prime Minister's focus in terms of holding me account to deliver on behalf of him and his government is on services for patients and the quality of care, the speed of access, and most importantly, the outcomes. And so in terms of how I spend my time, in terms of where my focus is, my first and foremost focus is always on, are we bringing down waiting lists? Are we going to be improving patient care year on year? There are some encouraging signs already, but as I keep on saying...
You don't think that this reorganisation is going to distract you from the progress made so far? I don't think that's the key thing. You may well will this.
It'll be disruptive. It's disruptive, certainly. Is it necessarily a distraction? No. We've got to remember, even in the context of a reorganisation of two entities, the department and NHS England, which have just under 20,000 people working there. This in the context of a system where more than 1 million people work. And on the day we announced the abolition of NHS England, and indeed the day after, there would have been people going to work in GP practices, in the community, in hospitals, in social care, going about their work just as they did the day before. And so we shouldn't think that just because we're spending quite a bit of time on a change management process with senior officials in the department or NHS England, that the rest of the system is stopped, waiting with bated breath for the next missive coming on the reorganisation.
But you were saying earlier that you keep in mind the Francis report. One of the things in the Francis report was that any major reorganisation should be subject to a risk and impact assessment. So you say that you don't, you're confident it won't have an impact. Has any impact or risk assessment been undertaken? And if not, when will it be undertaken and when will it be published?
Yeah, we will certainly, in the way the government normally does, do an impact assessment of changes, and we will be looking at impact through a range of lenses.
When?
Throughout the process, but I can report back to you in more detail down the line.
At the beginning of the process, or at the end? It's a bit late, isn't it?
We're at the beginning of the process now, but in terms of what will the impact of the changes be? Well, that would depend very much on how we constitute the new organisation and what it looks like.
Okay. Finally, you seem to at least keep the door open with regard to the possibility of PFI within the capital spend. And I just wondered, especially now that you've got Alan Milburn, who's an evangelist for PFI in some people's minds, where are you on that? And are there not lessons that you surely will have learned from the catastrophic impact that has had on NHS finances in the past?
I think I'd say two things about this. One is that with the level of capital underinvestment that was identified very starkly in the Darcy report, the pressure I feel constantly from parliamentarians who are constantly feeling pressure on behalf of their constituents about not just the new hospitals programme, but the crumbling hospitals and the primary care estate and the mental health estate and the community health estate and the new kit we need. There not only is there a historic undercapitalisation of the NHS, there are also ongoing and emerging capital pressures. I don't see how, even with the biggest capital allocation that the NHS has had since Labour was last in government, which the Chancellor delivered in her budget, I don't see how you deal with that challenge and the scale of that challenge without some private investment. The challenge, though, and this is why I kind of tread extremely cautiously in this area, and it goes back to the earlier point of pride in the last Labour government and what we achieved, but also humility about things that did not go so well. I am mindful that PFI came at a significant cost, and many trusts are still paying those costs, and that is not an inconsiderable cost for a number of trusts. But there are also different models of private financing. In Wales, the Welsh Labour government has been doing capital investment through private finance in a totally uncontroversial way. Many of the lift schemes that we saw in the primary care estate have been extremely successful. So I think it's kind of with that caution and that nuance in mind that we, will look at this. But I do want to reassure people that as we do, we are mindful not just of the good things the last Labour government did, but also the things we got wrong.
Learning lessons, and hopefully there's still the institutional memory to learn those lessons.
Thank you very much. Becky Cooper.
Thanks, Chair. I'm aware that we are running out of time, so I will be quick. Chris, you have sat there silently and stoically for 2 hours, so perhaps I might direct a question towards yourself. Public health, population health, with all the changes that are going on, NHSE being abolished, ICBs being cut by 50%, HSA presumably continuing as it is. Population health, where does that sit in this landscape at the moment?
Well, I think it's two answers to that. I mean, the first one is within the department. That's obviously separate from, in large part, if I could divide population public health prevention into two bits. The primary prevention bit, which is the things that government does, both local and national, broadly, is not really going to be affected by the changes in terms of the bringing of the NHS, because that's always been a separate function.
Sorry, just by that you mean that the local authority functions will remain as they are with the DPH as sitting, and we'll come to devolution in a minute, maybe for Jim, but carry on.
Well, let me complete the answer and then I'll come back to that. Secondary prevention, which is what happens when a clinician sits in front of someone and says, look, here's a risk factor, can we reduce it? That may be affected in operational terms by bringing together of NHS and DHSC, but in practical terms it won't. I'll go back to a point that the Secretary of State has made repeatedly in different ways, but I'll repeat it as well. For every clinician on the front line, for almost all the technical people and for most of the policy people, their day job will not change from one day to the next as a result of these changes. Because what they're doing is they're working for patients, they're working for the public, and that's what they should be doing. They shouldn't be spending their time thinking about reorganisations. So
Understood, Chris. So just if I can just perhaps direct your thinking to the department of known catchily as OHID. That is presumably obsolete now, or continues as is but will no longer be. Where does that health inequality mandate sit moving forward?
No, I don't think there's any reason to think that that's going to change, actually.
Okay.
And although PHE was abolished, OHID, which is really...
Yes, I think I said OHID had been abolished. It was the other way around.
No, right, yeah.
Excellent. Good to clarify.
Not set any new hairs running.
Yeah. Those functions are still very much present in the department. They are broadly divided into the group of things that are on the primary prevention I talked about, the secondary prevention facing the NHS, primary care, secondary care, and then research and data, which is off to one side. But the functions are still there and will still be needed.
Okay, excellent. And so do we foresee a world, not anticipating the 10-year strategy, where the functions of PHE, so HSA, the Health Security Agency, and OHID, and perhaps that sort of strategic level thinking, that we bring them more closely together again?
Well, I certainly think, and without in any sense prejudging the 10-year plan, the Secretary of State has made clear repeatedly that the shift from treatment and prevention is a key part of this, and he said in several of his answers today he wants to push things out further out to the periphery, but all of that can work with a public health system that's working. There will still need to be some central functions, which include data and research, which is much more efficiently done centrally, and primary prevention, which really has to be done by government under democratic control.
Excellent, thank you, Chris. And perhaps to Jim then, devolution. So it's been mentioned several times in this session. As we're aware, concurrently, local authority is undergoing a process of devolution, and for those areas in the country that don't have devolution, by the end of this Parliament, they are mandated to undertake it. How is devolution in health working alongside devolution in local authority, and do you foresee sort of areas of synergy or areas of issue arising?
Yeah, so it's a really big part of what you do locally when you're running trusts or ICBs. You're trying to work really well with local primary care, local council, and increasingly combined authorities where they exist. So it's absolutely a big part of what we want people to be doing, getting really close, joining up public services wherever possible, and maximising the value for the public.
And in terms of resources and responsibilities, do you foresee a point where integrated care boards are working so closely with combined authorities that there is a level of accountability into those combined authorities, perhaps looking at some of the accountability that currently comes to central government?
If you think about from a structural governance sense, a lot of this has still got to be worked through, and I'd agree with what Secretary of State said earlier on about being careful not to just end up in a position where we're loading people into boards for the sake of it, a sure representation. But the principle of being very aligned, very joined up in terms of strategic planning, impact for the population, would absolutely expect that. And some ICBs, coterminosity with combined authorities is a big thing. For them in the discussions we've had over the last few weeks. I know there's less so where it's less developed.
I think there's different appetite from some of our mayors as well. I think Andy Burnham recently put out some actually really interesting ideas and is doing some really interesting work, particularly in the prevention space, that I think we should look at. And I think one of the interesting things about Andy is that he's sat in my chair before and is now driving population health and prevention work as a mayor, and I think that's really good and really interesting. And I suspect if given the chance, we would probably take on greater responsibility in this area. Oliver Coppard similarly doing a similar agenda and similar ambition. I'm not sure every mayor would have the same level of enthusiasm or appetite, but we're certainly up for trying things differently and testing and learning. And certainly, some of the public noises that Andy's made about different approaches he'd like to try in Greater Manchester, we'd be really open to trialling and testing different things and seeing
great.
What works.
Yeah, and I think that aligns with the white paper that came out around devolution, where it does say that the mayor, it will be expected that they'll be appointed to one or more relevant integrated care partnerships. So that aligns closely. So I suppose my final question, Secretary of State, is for yourself. We're often accused in politics of using health as a political football. In terms of the changes that are now being undertaken, how will you ensure that for future Secretaries of State, these are seen as positive, nothing is ever apolitical, but positive, sustainable changes that are not simply undone by your successor or future successors?
Well, no Parliament can bind its successor, but I thought it was really encouraging, actually, how many of my predecessors, Labour and Conservative, were, to different degrees, welcoming the changes we're making, some more cautiously than others, some emphasising different opportunities or risks to different degrees, but broadly speaking, we have achieved broad consensus on this, and I don't think that is a bad thing at all. And I know there are some people who, whenever someone from the other side says something positive, kind of says, oh, this is proof that you're not being Puritan enough or ideological enough. But I think as far as possible, especially when it comes to the overall system architecture, it is a good thing if people know that from one government to another, from one party to another, although there'll be different policies and different choices, and we've got to make sure there is that genuine choice and contest, it is a good thing if overall you're building a national consensus towards the same overall direction.
So would you say this is the right balance between recovery and reform?
Yeah, I think so. I think we are seeing some signs of the NHS's recovery, and we are seeing radicalism from the government in terms of reform, and we are seeing that welcomed across the party political divide. I think that is a good thing. We will continue to work in this spirit, and I've been kind of delighted informally as well as formally to bring in people who might not kind of share our party colours, but care about the NHS and want to help this government. And, you know, in that spirit, I was delighted, for example, to have on the department's board Camilla Cavendish, who, you know, she worked for the last Conservative government, or not, I don't want to say literally the last Conservative government, there's so many of them, but a Conservative government over the last 14 years. But she's got great ideas on social care. She's a committed public servant. Why wouldn't we try and bring in people with that level of commitment, skills and experience? We won't always agree on everything across the party political divide, but against the backdrop of very fractious politics, I think it is a good thing to remind the public that we have more in common than the things that divide us.
Thank you.
Thank you. Well, that is as much an advert for select committees as I've ever heard one as well. So that's a good place to end. Thank you, all three of you, for appearing in front of us this morning.